Good decision making require a very thorough understanding and a systematic approach. Hello everyone and welcome back to Anesthesia and Beyond. My name is Dr. Simarpreet Singh Anand and today I've come up with a very interesting topic, that is interpretation of cardiac output monitor parameters in a systematic approach. So those of you who have seen the monitor, those of you who have used the monitor will agree with me that it gives you a lot of values, and sometimes it can be overwhelming just to see how many values are there on on the monitor screen. So what I'll try to do over next 15-20 minutes is I'll try to teach you basis of each and every value, that is stroke volume variation, SVRI, EA-dyne. Secondly, I'll give you one algorithm on how to interpret these values in a systematic way, and then what decision has to be made, whether it's a fluid, the inotrope, or the vasopressor, what your patient needs for increase in blood pressure or the cardiac output. Let's move forward now. I'll be switching off my video and we'll move forward with the lecture now. So this is how I have laid down my lecture. I will discuss a bit about the case. Now, why I always like to incorporate a case-based discussion in my lectures is that I want active learning and active participation from the audience as well. So I can teach you this the old-fashioned way, the ones you have been getting knowledge from, such as CMEs and conferences or some other YouTube pages, is that I just tell you what these parameters are. I'll show you the monitor screen and tell you this is cardiac index, this is SVRI, this is SVV, this is EA-dyne, this is DP by DT, and move forward. And finally give you one algorithm to take home and to take a screenshot of, which you will never see. And the problem with this type of teaching is that you don't have active participation. Now, what I will be doing over the next few minutes is I will be showing you this table again and again. These are the actual parameters of my patient, and I will be showing you each and every parameter so that you can have active participation once I have taught you each and everything. So don't panic at present. I will be showing you this page again and again, and finally the best part about this lecture, I will be giving you this algorithm. It is very simple. It is very simple. Just wait for it. I will be teaching you each and everything. We'll go very slow, and ultimately I will give you this algorithm. You can take screenshot of, you can share my lecture so that each and every person can get educated by this. So just a teaser, what I'm going to do is imagine yourself in the OT with me, and as soon as you have induced the case, your blood pressure has dropped to a drastically low 60 by 30. Now I'm dealing with a case of ejection fraction 15% here. And imagine giving 400 ml fluid in just a fraction of minutes, that is 20 minutes, which is completely against the conventional teaching of not giving them enough fluid and definitely not giving them boluses of fluid. And secondly, what if I tell you we used more of vasopressor than an inotrope in this case, which is again uh, against the conventional teaching of not increasing the afterload in these cases and having more of an inotropy. And over next 3.5 hours, we gave him approximately 1500 ml of crystalloid and one blood transfusion. Some might think at present, dude, this is too much. But trust me, I will show you how we made that decision, and ultimately this case was reversed on table, extubated, shifted to ICU, and sent back home on day 5. So let's move forward. So a case, we had a 63-year-old male who was a farmer by occupation who came to us with chief complaints of pain abdomen. He was diagnosed to have well differentiated adenocarcinoma. He was a known case of hypertension since last 2 years and was on tablet metoprolol and ramipril. He had MI 2 years back, and since then he was a known case of dilated cardiomyopathy, for which he was taking tablet digoxin and dietol. He was a known case of diabetes mellitus and was converted to insulin on admission to hospital. He had METs less than 4. On examination, he was an averagely built guy and he had a pulse of 70 per minute, a low volume pulse, and a blood pressure of 118 by 56. pallor was present on examination. Both his CVS examination and respiratory examination were within normal limits. So he had bilateral air entry and there was no added sound on auscultation. So a diagnosis of CA colon with dilated cardiomyopathy with hypertension and diabetes was made, and the patient was planned for subtotal colectomy by the surgical team. So perioperative investigation, he had a HB of 9. On ECG, he had T-wave inversion in lead 3, AVF, V4, 5, 6, and left middle branch block. And on chest X-ray, he had cardiomegaly. On echo, he had dilated LA-LV with ejection fraction of as low as 12 to 15%, with global hypokinesia and mild MR. This case was referred to us after denial from very big institutions. So we were really proud of taking this case and eventually extubating him and sending him home on day 5. So we gave him fitness under ASA 4. We took high risk consents, invasive procedures consent such as arterial line and CVP line, and obviously post of ventilator consent was also taken. We booked adequate blood and blood products. So the plan of anesthesia for this guy was epidural plus general anesthesia. Epidural for intraoperative pain plus post-op pain as well, and obviously general anesthesia since it was a major surgery. We secured a large bore cannula, epidural was placed. Both the radial artery and the central line, that is the right IGV cannulation, was done before induction of anesthesia in this case. Why? Because we had such low ejection fraction. We want beat to beat monitoring throughout the induction and throughout the case. And also, we wanted baseline values of his cardiac output. So that's why they were done preoperatively. Now, this case was induced using fentanyl 2 mics per kg, etumidate 0.3 mg per kg, and to facilitate intubation, we used 0.1 mg per kg of VEC, and we intubated him once TOF was 0. Now, despite this, I just told you that immediately as soon as we induced the case, despite using the most cardiostable drugs, the blood pressure dropped to a drastically 60 by 35. So how we manage the case is what is the most interesting part about this case is. So dobutamine infusions and norend infusions were started to maintain blood pressure and inotropy, doses of which changed throughout the surgery, and what it was based on the hemodynamic response and requirement. That was guided by our hemodynamic monitor. And depth of anesthesia monitoring was done by BIS and neuromuscular monitoring by TOF. Urine output monitoring was done hourly intraoperatively because it's a surrogate of organ perfusion. We had a blood loss of approximately 350 ml and patient was reversed, extubated, shifted to ICU on the very same day. And we are really proud of this. So if I have to explain you the parameters, I need to explain the physiology behind it. So cardiac output is equal to heart rate into stroke volume. Now, before I move forward, I want to make a disclaimer that this lecture is an add-on layering to a previously uploaded lecture, that is evaluation of a cardiac patient posted for non-cardiac surgery. You might have noticed that I have not dealt with the evaluation part. So in that previous lecture, I have given a 6-step approach on evaluation of a patient. And trust me, this comes 100% in your exam in both MD and DNB. If you see past 10-year question papers of your institutional MD exam or the DNB exam, you will realize that in some form or the other, that question has been asked again and again and will be asked again and again. This lecture, this point is coming recently in your recent advanced paper. So it's a win-win thing for both the things. And especially for postgraduates, I request, if you have not seen that video, please see that video and then come back because it's a bit advanced lecture. Now, let's start again with the lecture. So you might have seen this graph. So this point is the mitral valve closing. This is the isovolumetric contraction. Then the aortic valve open, the left ventricle contracts, the aortic valve closes, the isovolumetric relaxation, and the mitral valve opening. And this is the passive filling. This is the passive diastolic filling. And in between is the stroke volume. Now, stroke volume is dependent upon preload, afterload, and inotropy. So I will be talking about these 3 arms again and again and again, that if you know what your patient needs, particularly you can have a better outcome for your patient. Whether the preload arm is hit, whether the afterload arm is hit, or whether the inotropy arm is hit. So the middle part is a control. If I decrease the preload, examples such as in hypovolemic shock, the preload is decreased, the stroke volume decreases, the mean arterial pressure will decrease. And simultaneously, if I increase the preload, the stroke volume increases, so will be the cardiac output of the stroke volume. The second arm is the afterload arm. So the middle part is the control arm. Now, if your patient have increased afterload, you can clearly see the stroke volume getting decreased. And if you have a decreased afterload, you can clearly see that the stroke volume will increase. And the third arm of managing such cases is the inotropic arm. Now the middle part is again the control part. Now if your patient is having decreased inotropy, you can see the stroke volume decreasing. And similarly, if the inotropy increases, that is the red box, you can clearly see the stroke volume increases. Now make a judgment for yourself what your patient needs. Example I'll take in my case. My case is a case of DCM with ejection fraction of 12%. Obviously, the inotropic arm is the most hit, means my patient will have a lower inotropy. Now, if I want to tell you the anesthetic goals, it's to prevent tachycardia, maintain inotropy, prevent increase in afterload, and maintain adequate preload. But if you remember in the starting of the lecture, I just told you that I used more of vasopressor as compared to inotrop. But trust me, I will justify this. I will be truthful to my anesthetic goals as well, that I will maintain inotropy at the end of the lecture. My patient will have not increased the afterload to such an extent that my cardiac output has decreased. And obviously we will try to maintain preload. Now, again, I'm showing you the same monitor what I used. So imagine yourself looking at the monitor, you see a lot of parameters. SVRI, PPV, SCVV, EA time, dP by dt, CCE, and above other arterial waveforms. So how to interpret these things? How to interpret which arm is for preload, which arm is for afterload, and which arm is for inotropy. Now I'll be explaining you that. Now this is the same table I showed you initially. For your study pleasure, I have demarcated it by different color codings. The preload arm will be demarcated by blue color, the afterload by yellow, and inotropy by green color. So the two parameters in my preload arm are the SVV and EA time. Don't panic, I will explain what these mean, what are the normal values, and what has to be done if you have a deranged value. The afterload arm is depicted by SVRI, that is the systemic vascular resistant index, and inotropy is dependent upon or is showed by dP by dt. So what are my preload arms? I just told you first is the stroke volume variation. Now what is stroke volume variation? Basically it's the difference of stroke volume during inspiration and expiration, and it's based on the physiological Frank-Starling curve. Now if your patient is having a stroke volume variation of more than 10, means your patient is fluid deficient. And if your patient is having a stroke volume variation of more than 10, means your patient is normovolemic. Now just think for a second, just by giving fluid, will my blood pressure increase? Is my question number 2. I've asked question 1, whether my patient is fluid deficient. Now I'll ask question number 2, whether just by giving fluids my blood pressure will increase, and that is depicted by EA time. I'll show you the diagram in the next slide. But what is it? It is basically the whether my fluid deficient patient will respond to the fluid given. Now, if you go in your basic sciences, you know blood pressure definition. It's that the lateral pressure exerted by the blood flow. Now, if your vessel wall is normal, the fluid I give will produce some lateral pressure and thus ultimately increase my mean arterial pressure. But if you have a vessel like this, despite giving fluids, your blood pressure won't increase. So now, till now, what you have done is you have understood whether your patient requires fluid, that is by SVV, And second question was whether my patient is fluid responsive. That is, just by giving fluid, will my mean arterial pressure increase, or it's just waste of time and obviously resources that I'm giving fluid, but my mean arterial pressure is not increasing. So two things are done. My preload arm is done. I will show you the parameters again. Wait for it. The second arm is the afterload arm. And the surrogate of afterload arm will be the systemic vascular resistance index. And third but not the least is the inotropy arm. So the parameter for inotropy arm in my discussion will be the systolic slope, that is dp by dt. So we have amples of monitors such as flow track. Flow track gives values in mmHg by second, and Vigon monitor gives values in mmHg by millisecond. So my discussion will be mmHg by milliseconds. So what is it? If you have seen an arterial waveform, it's the arterial upstroke. The steeper the stroke, it's better the cardiac output or the cardiac contractility. A normal value of 1250 mmHg by seconds. And if I have a slanting upstroke, means my contractility is low. Okay, so this is how I have written my values, that is in mmHg by milliseconds. So you can easily interpret that a value of 0.9 to 1.3 means a normal LV systolic function. Increased LV systolic function will be depicted by a value of more than 1.3, such as in hyperdynamic circulation. And if I have a decreased LV systolic function, such as in my case, you will see that the dp by dt will be mostly below 0.9, especially at the starting of the surgery. So again, a small example on how to interpret or how your monitor interprets this is the one. Here is the normal contractility, and as the angle goes down, there is decreased contractility. So systolic slope is the maximum slope of arterial pressure waveform measured from the peripheral arterial line, and it's a surrogate of ventricular contraction. Now mind you, you should take its trend and not an absolute value. So your machine will give you, or the monitor will give you a trend. It won't give you a value, single value. It will give you a trend. So we should always, our decisions should be based on trend rather than a definitive value at that point. Now again, I am coming back to this. This is the third, fourth time I am showing you this. So preload arm, afterload arm, and the inotropy arm. Everything in blue will be the preload arm because next slide is the algorithm. Everything in yellow will be the afterload arm, and everything in green will be the inotropy arm. So now I am giving you the algorithm. This is the algorithm that I'm very proud of that we made. So now your patient is having low mean arterial pressure. Always and always these things are interchangeable. So I have to take care of three things, three arms: the preload arm, the afterload arm, and the inotropy arm. So let's move forward with the preload arm first. So first thing first, I will look for the stroke volume variation. The first question I asked is whether my patient is fluid deficient. Now, if I have a value of more than 12, yes, my patient is fluid deficient. But that is not the end of it. The second question I ask in this arm is whether my patient is fluid responsive, that whether giving fluid will have some impact on the mean arterial pressure. That is taken care of by EA time. So stroke volume variation, if it's high, I go with the second question, EA time. Now, a value of more than 1.2 means my patient is fluid responsive. Means just by giving fluids, my mean arterial pressure will increase. And if I have a value of less than 0.9, means just by giving fluids, my patient won't respond to it. There won't be lateral pressure to increase the mean arterial pressure. Means I need to add vasopressor with this. So vasopressor along with fluids. Now you can see I have done make these interchangeable arrows. The second question, you always have to ask all three questions. The second question will be, okay, what is the afterload? That is depicted by SVRI. If it's low, that is less than 1800, means your patient requires vasopressor as well. If it's normal or high, I will go to the inotropy arm, which is depicted by dp by dt. And if it's low, means my patient requires inotropy or my patient requires a decrease in afterload. So pause this video, go through it again, because next I will have an interactive session with you, and I request you to pause the video, make a decision for yourself, and then listen to me that what I did in that case. So let's move forward. I'll be coming back to this slide again and again. So again, now I'll be showing you what values I have inserted in this. So my patient at parameters. First is the stroke volume variation. I've asked question number 1, whether my patient is fluid deficient. Now see the value, it's 25%. So pause the video, think for yourself, and now I'll explain. Yes, my patient is fluid deficient. And how I know that is by the previous paragraph or the previous algorithm. SVV of more than 12% means your patient is fluid deficient. Question number 2, that is the EA dyne. Whether my patient is fluid responsive. So I have a value of 0.07. I just told you if my value is less than 0.9, means my patient will not be fluid responsive. Irrespective of me giving fluid, the mean arterial pressure won't rise. Okay, the first question is asked. The preload arm is done. Now second arm, the afterload arm, the SVRI. Now if I have a value less than 1800, I know my SVRI is low. I am vasodilated. So look at the value. It's 1100. Oh, so you can easily interpret that this patient was vasodilated. Means he has a very low afterload. And the third thing is the inotropy part. dP by dt. I just told you a value of less than 9 means your patient is having low inotropy. And obviously my patient was having global hypokinesia. So the value of 0.8. Now think for a moment which two arms are the most drastically hit arms. And if you're ready for the answer is the preload arm and the afterload arm. My inotropy is still very near to my threshold, that is 0.9. But just look at SVR and SVV. A normal value of 12, a normal value of 1800. I am way far below them or way far above them. So the intervention we did in this point at this point was I gave more of fluids and I used more of a vasopressor than an inotropy. So inotrop was added to maintain that inotropy. So imagine this thing, now you are dealing with a case of 15% ejection fraction. You can't increase the inotropy to 20-30%. That won't happen. You can maintain the inotropy. Whatever is left for your patient, you will have to maintain it. You can't be God that you increase inotropy to 50% by just giving more of dobutamine or dopamine. So in this case, at this point, I gave more of fluid to correct this. I gave more of NORAD to correct this. And I used dobutamine to maintain this. And see for yourself what my blood pressure was at this point, 60 by 35. Now 30 minutes in the surgery, I again see the monitor. My stroke volume variation is 22. Now, is my patient fluid deficient? Yes, he is still fluid deficient. Now I ask question number 2, EA dyne. Whether my patient is fluid responsive? The answer is still no. He still needs vasopressor. Now coming to the third point, the SVRI, that is the afterload arm. My afterload is still low. It is not increased to an extent that I increase the oxygen demand for my heart and decrease inotropy, but it's still low. And my dP by dt has somehow increased to 0.9. So see what we did here was we gave him blood transfusion. We kept NORAD at a higher dose and dobutamine. And eventually you can see the blood pressure also rising, but still the mean arterial pressure was less, that is 55. That is the organ perfusion is still low. Now 1 hour in the surgery, my stroke volume variation is 10. It has normalized. My EA dyne has normalized. My SVRI is increased but still low. I told you initially goals of anesthesia, and I told you that I have to decrease afterload, but not to an extent that I have sudden drop in blood pressure. So my SVRI is still low, but not to the point that my mean arterial pressure is low. And look at the dP by dt. I have a normal dP by dt. So look at the blood pressure now. It is 122 by 75 with a mean of 70. And over second and third are similar things happen. I request each and everyone to pause the video to understand this point. and go step by step and see what we did and what you would have done, and see how the parameters change going from this point to this point and this point to this point accordingly, depending on the time. And see, for the first, second, and third hour, what we did was overall we gave him 800 ml of fluid in these 3 hours. We used a very minimal dose of NORAD and we used a very minimal dose of dobutamine throughout. And after this, my patient was extubated on table, extubated, sent to ICU, and shifted to home on day 5. That is a win-win for the patient, for the anesthesia team, and the surgical team. And how we could make the decision of giving him such high volumes of fluid, now you can judge that. Now, a disclaimer: were we not aware that what can happen with such high volumes of fluid? We were aware of that. We had backup ready. If the patient goes into pulmonary edema, what has to be done? So this takes some time to understand, to interpret. So this is a ever learning curve. So don't go home and use this thing straight away on your patients. Take some time to understand it. Use it over some ASA 1 patients maybe, or ASA 2 patients, to understand how this works, and then only start using it in higher cases. So have I not justified all the anesthesia goals I just told you? That is to prevent the tachycardia. I maintained inotropy. I did not increase the afterload. I maintained an afterload to a lower limit of 1800, and I maintained adequate preload. So I have justified my talk. I have justified my anesthesia goals. So before I end, there are few slides left. If you like the lecture, please subscribe, like, and share with your colleagues so that they can also get enlightened with this difficult topic somehow. And there are various hemodynamic monitors. What I discussed with you was the most care monitor or the flow track monitor by Edwards. But even your pulse oximetry is a minimally invasive, it's not an invasive, it is also a hemodynamic monitor. What it can tell you is the pulse pressure variation. And the age-old, the pulmonary artery catheter is also there. But obviously it is going out of practice with upcoming advancement in the minimally invasive hemodynamic cardiac output monitors. So whether to use, whether not to use, it is a class 1 recommendation to apply goal directed hemodynamic therapy in such cases. It's a class 1A recommendation. So it's my advice that if you have these monitors, please use this in such cases. So a take home message: minimally invasive hemodynamic monitors should be regularly used for your patient with underlying cardiac diseases, and for all patients, irrespective of their cardiac disease or irrespective of the cardiac status, for major surgeries. And it's a class 1 recommendation as well. So there are various hemodynamic monitors available in the market, and it's up to your institutional and personal familiarity with the instrument and the technology that you should choose. So obviously the more familiar you are with the monitor, the more familiar you are with the technology, the better decisions you can make at the end of the day. So thank you very much for your patient listening, and I hope you learned something. And if you learn something from this lecture, at least I deserve a like from you. Please share and subscribe to my channel. And if you want any further lecture such as on 2D echo, you please comment down in the comment section. So maybe in near future I can make lectures on that. Thank you so much.